Good day, everybody. I'm Anna Plotkin, Director of Continuous Professional Development at the University of Toronto, and today we have our semi-annual breast community of interest. It is my great pleasure to introduce the organizer for today's meeting, Jessie Wu, who is a breast pathologist at the Unity Health. And Jessie will be taking over from Nicolina, who did it for a number of years, and we're really grateful for all the work that Nicolina did for the breast community. I also have a pleasure to introduce two moderators, Anna-Marie Mulligan from the University Health Network and Sharon Nofech-Mozes from the Sunnybrook Health Sciences Center, both from Toronto. We have an amazing keynote speaker, but I would like to pass it to Jessie to introduce our keynote speaker. And have a great time, and thank you for joining us, and thank you for contributing all the cases. Jessie?
Thank you, Anna. Thanks everyone for attending the Breast Community of Interest meeting today. My name is Jessie Wu, and like Anna said, we have an excellent lineup today. We're going to kick off the meeting today with a lecture on approach to the diagnosis of fibroepithelial lesions. And this is a particularly timely topic. As many of you are aware, CAP released a reporting protocol on Felodi's tumor just in March, and certainly from my own practice, I know that kind of classification of Felodi's tumor can be particularly challenging. And with that, it's my great pleasure to introduce Dr. Andrew Lee. I was very fortunate to have been one of his trainees. Dr. Lee is a consultant histopathologist at Nottingham University Hospitals, and one of his many research interests is in fibroepithelial lesions. He has over 200 peer-reviewed publications, numerous book chapters, and was also one of the authors of the Royal College of Pathologists reporting guideline for breast diseases. So without further ado, please join me in welcoming Dr. Andrew Lee.
Can everybody hear me? Is that all right? Yes. Well, thank you, Jessie, for your very kind introduction. I think you overpraised me, but anyway, it's a great pleasure to talk to you today about an approach to the diagnosis of fibroepithelial lesions. I'm afraid I'm going to approach this from a European angle, so I hope it's not too different from the CAP guidelines. I'm going to talk about essentially the difference or distinction between Felodi's tumors and fibroadenomas. Initially, I'm going to talk mainly about surgical specimens, mainly about Felodi's tumors, with a little bit about grading and so on. And then for the second half, talk about the diagnosis of fibroepithelial lesions on core biopsy. So I'm not going to talk about all these numbers, but essentially what I want to make is 2 or 3 points. First of all, fibroadenomas are much more common than Felodi's tumors. For every 100 fibroadenomas, there's only 1 or 2 Felodi's tumors. It's actually quite difficult now to make that comparison, because certainly in Nottingham, there are many women who have a clinical and radiological diagnosis of fibroadenoma and don't undergo biopsy. The other point is that Felodi's tumors are difficult. Over a 5-year period, we diagnosed just over 30 in Nottingham. We have about 700-800 breast cancers a year, so it gives you some idea of the figures. But we have more than twice as many of that we receive in consult cases, so I think they are tricky cases. I'm not going to talk much about fibroadenomas in surgical specimens. I just want to make one point. So here's a typical appearance, low power architecture, nice circumscribed lesion, intracanalicular growth pattern, and most of it has a typically low cellularity myxoid stroma. But this is one area within this lesion. It's not uncommon, in addition to seeing the very bland nuclei, to see quite plump nuclei in places. So I would ignore this degree of atypia in a fibroepithelial lesion, including a fibroadenoma. On its own, I don't think it means very much. So I'm sure you're all aware of the features we use for distinguishing Felodi's tumors and fibroadenoma, and you're aware of this list. And if you've got a malignant Felodi's tumor or borderline Felodi's tumor, and usually these features are well developed. So in a malignant one, you will often have an irregular edge. There may be a leaf-like architecture, and these stromal features here, cellularity, pleomorphism, so on, are likely to be well developed. So as long as you've got an epithelial component, usually the diagnosis at that end of the spectrum is straightforward. I think often much more challenging on surgical specimens is the distinction between benign Felodi's tumor and cellular fibroadenoma. And for both of those, they usually have a circumscribed edge. A leaf-like architecture is almost always present in a Felodi's tumor, but it can also be present in a fibroadenoma. Usually there are few mitoses, no overgrowth, minimal pleomorphism, and often you're relying a lot on the presence of stromal cellularity, which is quite subjective. So I'm going to take you a few pictures. So here you can see a circumscribed fibroepithelial lesion at the edge. It's very circumscribed, but there's clearly expansion of the stroma compared with a typical fibroadenoma. There are leaf-like areas. Interestingly, there are areas that look like a typical fibroadenoma, and the heterogeneity, which I'll come back to, is quite common in fibroepithelial lesions. And at higher power, the cellularity is clearly more than a typical fibroadenoma. So I've categorized this as a benign Felodi's tumor. Another example here, again, clearly circumscribed, and even at low power, you can see clearly the leaf-like architecture. But if you look at medium or higher power, the cellularity, if anything, is low compared with a fibroadenoma. So I think in Nottingham, we would categorize this as a fibroadenoma with a very prominent leaf-like architecture. Another example here. Here you can see again a very circumscribed edge, but even at this low power, you can see there's areas of expansion of the stroma and clearly increased cellularity. This lesion, I think there were just literally 1 or 2 leads. Most of it had a pericanalicular architecture. But at this degree of cellularity, I don't think you can call this a fibroadenoma. So despite the fact that the architecture is not typical, I think this degree of cellularity pushes you to calling this a Felodi's tumor. Juvenile fibroadenoma can be quite tricky. They can be large and grow rapidly. I think useful features are that there's usually a pericanalicular architecture. There is often some mild degree of increase in stromal cellularity, but it's not marked. And I think another useful feature is that the stroma and epithelium are usually in proportion throughout the lesion. And you rarely, if ever, see stromal overgrowth. And epithelial hyperplasia, often rather gynecomastoid, is a very common feature. And you can see mitosis, you can sometimes see a few, particularly in these lesions which often occur in young women. So a couple of big pictures. Here you can see a mild increase in stromal cellularity and clear epithelial hyperplasia, rather gynecomastoid pattern. Another example here again with hyperplasia and perhaps a little bit more increase in stromal cellularity. And these can be quite difficult to diagnose with certainty on a core biopsy, so I would tend to err on the side of caution with these. Heterogeneity, I've mentioned, is a common problem. So this was within a Felodi's tumor. Above the gland, you can see low cellularity, if anything. Below, clearly increased cellularity and also cytological atypia. Another example here, there was a leaf-like architecture, but within this leaf, some slight pleomorphism, but nothing significant, and no mitoses or really significant increase in cellularity. But elsewhere in the same section, you can see clearly increased cellularity and about 3 or 4 mitoses just in this one high power field. So if you get this sort of heterogeneity, if you can make a diagnosis, fine. If there are enough features to make a diagnosis of Felodi's tumor, fine. But if uncertain, what I'd recommend is you try and take more blocks, and that will usually push you one way or the other. So I think the key feature for benign Felodi's tumor is stromal cellularity, a mild increase at least, and a leaf-like architecture is almost always present, but it can also be present in a fibroadenoma. And often the other features such as pleomorphism, overgrowth, you really don't see, and you only usually see a few mitoses at most in a fibroadenoma. And for both of these, the fibroadenoma and Felodi's tumor, the margin will be circumscribed. So I think key features, cellularity and a leaf-like architecture. So as I say, no single feature can be relied on, but the more features you see, the more likely you are to make a diagnosis of Felodi's tumor. Lots of studies of immuno have been done, but I think essentially it's of no value. So things like proliferative markers, there's an overlap between these 2 lesions, so I don't think it's actually of value. So I think just old-fashioned H&E, which suits old-fashioned pathologists like me. But there's no clear cutoff between these two, between benign Felodi's and cellular fibroadenoma, not surprisingly, poor reproducibility. I think the WHO has a very reasonable recommendation, if you're uncertain, recommends categorization as fibroadenoma. I'm a simple diagnostic pathologist, but I'm going to briefly mention the genetics because I think it's of interest. As I've emphasized, there's a morphological overlap really between cellular fibroadenoma and benign Felodi's tumor, and the same is true of the genetics. So MED12 mutations are common in Felodi's tumors, particularly at the benign end of the spectrum, but they're also common in fibroadenomas, particularly those with an intracanalicular architecture. And what is interesting is that the same mutations, missense mutations and codon 44, both in fibroadenomas and in Felodi's tumors. There are some genetic differences. TRT promoter mutations are more common in Felodi's tumors, but they can be seen in a few fibroadenomas. And cancer driver genes such as P53, retinoblastoma, EGFR really are restricted to borderline and malignant Felodi's, and usually you can make an H&E diagnosis of those. So going to the more malignant end of the spectrum, here's an example of stromal overgrowth, and the usual or the classical definition is a ×5 or ×4 field with no epithelium in it, just stroma, no epithelium. I think one has to be slightly cautious about this because the classical papers from 50 years ago were with different microscopes. So I think the field diameter now is broader than it was, so maybe we should adjust that slightly, that definition. Here's an example with marked pleomorphism, and I think that's straightforward. One point here, you can see a lipoblast, but a lipoblast does not mean liposarcoma and does not mean malignant Felodi's tumor. What you need to do is look at the cells adjacent. After all, you can get lipoblasts in an atypical lipomatous tumor, and the breast is a subcutaneous tissue. So I think you have to be essentially look at the adjacent cells, not just rely on the odd lipoblast. So here's another example here with lipoblast, and here you can see there was some condensation around these glands. It was a very prominent adipose tissue component, and even at this power, you can see there's atypia and cellularity, yes, here at higher power, atypical mitosis and pleomorphism. So those are the features you should base your malignant diagnosis on, not the odd lipoblast. And interestingly, the genetics of liposarcoma in Felodi's tumor is different from extramammary liposarcoma. So there does seem to be a difference between this and at other sites. And another point, if you see liposarcoma in a core biopsy in the breast, it's actually more likely to be part of a Felodi's tumor than a mammary liposarcoma, although you do occasionally see primary and occasionally metastatic liposarcomas in the breast. And another useful feature at the malignant end of the spectrum is an infiltrative margin like this. So at this malignant end of the spectrum, the differential diagnosis is spindle cell carcinoma or sarcoma. And I think the key thing here is to sample thoroughly. For diagnosing Felodi's tumor, you need to try and find the benign glandular component. For carcinoma, look for epithelial differentiation, which may be conventional invasive carcinoma or DCIS. Also, or you may just look with cytokeratin immunohistochemistry. And CD34, which I'll come back to, is a useful marker of Felodi's tumor. So this is old data from Nottingham, from a study which we did around the time I arrived in the 90s. Malignant spindle cell lesions of the breast, metaplastic carcinoma is much the commonest, malignant Foley is number 2, and angiosarcoma is the least rare of the sarcomas. I'm going to talk briefly about prognostic factors, and for local recurrence, most studies will find an association between margin status and local recurrence. But even if it reaches the margin, recurrence is not inevitable, and there's no consensus on what an adequate margin is. Certainly, after all, for breast cancer, which is much more common, there's controversy about what an adequate margin is. And there are certainly no prospective studies I'm aware of looking at the distance to the margin and chance of recurrence for Felodi's tumor. But if you have complete excision with it not at the margin, the local recurrence rates are low. There's some studies suggesting there's an association with grade, but I think that's weaker than for margin status. So I think a reasonable approach is to recommend complete excision, at least for borderline and malignant. And I'll talk in a moment about a wait and see policy for benign Felodi's tumors. This is a large study from Pui Hoon Tan's group in Singapore, and she has done a lot of work on Felodi's tumors. So most benign Felodi's tumors will come back as benign if they recur, but some will come back as higher grades. Borderline will usually come back as borderline and malignant, and most malignant will come back as malignant. So talking about this wait and see approach, which is certainly used in some European countries, I don't know what the approach will be in America or Canada. Many Felodi's tumors are not diagnosed preoperatively. As a result, incomplete excision is common. As I've already mentioned, local recurrence is not inevitable, and most recurrences, if it's benign in the surgical specimen, will also be benign. So a wait-and-see approach is an option if it's a benign lesion, and certainly in Nottingham, we would discuss it with the patient, and different people have different approaches to the risk. I don't think it's appropriate for borderline and malignant, and we would recommend complete excision in that group. So then you could argue, if you're not going to excise the benign Felodi's tumors, which I think the majority are not excised in Nottingham, you could argue, does the distinction between fibroadenoma and Felodi's tumor matter? I think one of the problems is there are no studies of the wait-and-see policy of lesions that are at that margin between Felodi's tumor and cellular fibroadenoma. And ideally, we need large prospective studies done by someone much younger than me, so you can have long follow-up. So you could argue that, in fact, the diagnosis of borderline and malignant Felodi's is more important because you're definitely going to re-excise those. Grading is a controversial area. This is the WHO system. So for benign, you have a lesion which is at a well-defined margin, mild or increase in cellularity, minimal or no atypia, low mitotic count and no overgrowth. And malignant, infiltrative margin, marked cellularity and atypia, high mitoses, and often overgrowth, and intermediate features for borderline. I think one of the major weaknesses of this WHO system is it's rather rigid. And not all tumors neatly fit into one of these categories. They may have some features of one category and some of another. So I think a system with some flexibility is a good idea. And I'll mention the approach we use in Nottingham based on a paper by Chris Moffat. Another thing is, should each feature be given equal weight? For example, there's quite a lot of evidence that stromal overgrowth is a particularly important feature suggesting malignant behavior. So maybe you should put more emphasis on that. Also, cellularity and atypia is quite subjective, and there are no objective criteria. So because of all this, it's not surprising that the proportion of benign, borderline, and malignant in different series is widely variable. Numerous biological markers have been studied and shown to correlate with grade, but I don't think they add much to routine H&E assessment. So this is the approach we use in Nottingham, which is based on a paper by Chris Moffat, quite old now. So essentially, we look at 5 features similar to the WHO: pushing margin more than 90%, and mild or moderate stromal overgrowth, cellularity or pleomorphism, and a low mitotic count. This is actually quite a small field area. It was up from an old microscope. And at the other end of the spectrum, malignant Felodi's tumor, infiltrative margin more than 50%, moderate or marked stromal overgrowth, cellularity and pleomorphism, and a high mitotic count. If 4 of the 5 features are present in the benign, we call it benign, so there's a bit of wriggle room, and 4 or 5 are present in malignant. The malignant features, we call it malignant. If it doesn't fit into either of those, we call it borderline. In this study, necrosis and heterologous elements were only seen in malignant lesions, but I think you can see heterologous elements in benign and borderline Felodi's tumors, so I wouldn't use that criterion. And I think if you apply these criteria, about 70% of Felodi's tumors are benign and about 10 to 15% are borderline or malignant. So that's local recurrence. If metastasis, there's a clear association with grade. This is a recent review which looked at data since 2000. 17% of malignant Felodi's tumors metastasize, just over 1% in borderline, and a tiny fraction in benign. So there's a clear, strong relationship with grade. Metastases, the axillary nodes are rare, so routine axillary surgery is not recommended. So that's a brief run through on surgical specimens. So the second half of my talk, I'm going to talk about preoperative diagnosis. So the management of fibroadenomas has changed dramatically in my working lifetime. When I was a student in the early 80s, all of these lesions were excised. Now, fibroadenomas and hamartomas are usually not excised, whereas we would recommend Felodi's tumors are excised. Most fibroadenomas are straightforward to diagnose on a core biopsy. Here you can see the myxoid stroma, elongated strands of epithelium, so the intracanalicular architecture, a straightforward diagnosis. It's useful to compare the stroma here, slightly myxoid within the lesion, with the normal stroma adjacent, and also see the circumscribed edge, which is often present in a core biopsy. And even if it's sclerosed, if you've got the intracanalicular architecture like this, you can make a diagnosis on a core biopsy. Hamartoma, I think, can be a bit more tricky to diagnose. You may have pseudoangiomas of stromal hyperplasia, rather jumbled arrangement of glands, so not the typical lobular architecture, and also often adipose tissue within the lesion. But I think often it's difficult to make a definite diagnosis of hamartoma on core biopsy. You can merely say the lesion is benign. Maybe the radiology will give you clues which will make you enable you to make a more definite diagnosis. So looking at Felodi's tumors at the malignant end of the spectrum, if, like this example, there's the normal benign epithelium within the lesion, then I think the diagnosis is straightforward usually. So here you can see highly cellular lesion at higher power, clear atypia, necroses, abundant mitosis. You can make a malignant Felodi's diagnosis in this sort of case. This was a woman who sadly had multiple recurrences. This core just had spindle cells, but because the stroma looked just like that in the previous Felodi's tumors, I was happy to make a diagnosis of Felodi's tumor, even though there wasn't any epithelium in this case, because it looked just like it and is in exactly the same place. Sometimes if there's no previous history of Felodi's tumor, you have a lesion like this with a mixture of polygonal and spindle cells. The differential here really is between carcinoma and Felodi's tumor and the rare possibility of sarcoma. So in trying to exclude carcinoma, which is the most common diagnosis, a whole panel of epithelial markers were negative, but CD34 was positive. And I think this is one circumstance in which CD34 is a useful diagnostic marker. And in this case, so we suggested it was malignant and favored Felodi's tumor, and the excision showed similar cytology with the Felodi's architecture, so it was a Felodi's tumor. So CD34 is positive in all fibroadenomas. Obviously, you diagnose fibroadenoma on H&E. Positive in the majority of Felodi's tumor, even at the malignant end of the spectrum. And I've not seen convincing staining in a spindle cell carcinoma. Also positive in myofibroblastoma and pseudoangiomas of stromal hyperplasia. Importantly, from the differential diagnosis of spindle cell fibromatosis like spindle cell carcinoma, fibromatosis is negative with CD34. In our series, sarcomas were negative, but you do get some sarcomas that are positive, and we've seen a few DFSPs which are strongly CD34 positive. So you need to integrate the morphology as well as the immuno. Another pitfall is that keratin expression can be seen in Felodi's tumors. To be honest, in this series, also from Pui Hun Tan's group in the Far East, a lot of these had a typical architecture of Felodi's tumor, so I wouldn't have done the cytokeratin in the first place. But you do occasionally get difficult cases, so it can potentially be a pitfall. Turning to the differential between benign Felodi's tumor and fibroadenoma on core, we use the term cellular fibroepithelial lesion. I don't know what term you use in Canada, for lesions where you're considering the possibility of Felodi's tumor, but not enough quite to make a definite diagnosis. And the proportion of these turn out to be Felodi's tumors is very variable in the literature. So in the literature from 16% up to over 70%. We're at the upper end of this spectrum. So one from my colleague Iman Raka and one paper by me, we're about 70%. And I think if you're down about 20%, you're probably overdiagnosing minor changes. So in terms of what is useful for this distinction between fibroadenoma and Felodi's tumor, there have been two approaches in studies. Some people start with a cellular fibroepithelial lesion and see what the surgical specimen turns out. Some start from the excision diagnosis and then see what the previous core showed. And these have had similar results, so I'll combine the two. A key feature is stromal cellularity. If you've got moderate or marked cellularity like this, it's straightforward, but more commonly you'll see a mild increase in cellularity like this. I've already mentioned heterogeneity, and that's common again in the core biopsy. So this core had areas of mild increase in cellularity, but also areas that had a low cellularity. So we would usually say, as long as there's a reasonable proportion of mild increase, that's a worthwhile feature. An intracanaliccular pattern, even if there's clefting, is not useful. It's seen in a similar proportion of both fibroadenomas and Felodi's tumors. We find fragmentation useful. This was a feature that was suggested to us by the radiologist who said that when they took a core from a Felodi's tumor and put it into the pot, it often broke up. So here you can see a chunk of stroma. At one end, there's some epithelium, and at the other end of the epithelium. And I think this is a reflection of the leaf-like architecture. So if you imagine taking a core across one of these leads, you get a bit of bit of epithelium, bit of stroma, and a bit of epithelium at the other end. So it's a reflection of the leaf-like architecture. You do occasionally see it in fibroadenoma. Some mild degree of atypia like this can also be seen in a fibroadenoma. If you get marked atypia like this, usually there are plenty of other features to push you to say it's Felodi's tumor rather than fibroadenoma. And here you can see mitoses. One or two mitoses or no mitoses doesn't push you one way or the other. One or two mitoses is more common in a Felodi's tumor, but you can occasionally see it in fibroadenoma, particularly in young women. 3 or more mitoses per 10 high power fields is quite strong evidence in favor of Felodi's tumor. Stromal overgrowth, I think we use a different definition from surgical specimens. So a ×10 field like this with no epithelium in it, we would call stromal overgrowth in a core biopsy. So the following features are consistently of value in different studies. So stromal cellularity, we use at least mild cellular increase in at least half the biopsy. Stromal overgrowth defined as a ×10 field with no epithelium. Stromal mitoses, particularly 3 or more. Marked stromal pleomorphism, usually there are other features, and fragmentation. These features are not of consistent value, so I wouldn't put any weight on those. And intracanalicular growth pattern and leaf-like architecture are not of value. So most of these features are not completely specific. The best used in combination, the more features you have, the more likely you are to make a diagnosis, definite diagnosis of Felodi's tumor. Exactly how we should combine them, I think, is something that needs further research. I've already mentioned heterogeneity, and I think this is the cause for what I would call false negative core biopsies. By that I mean the excision shows a Felodi's tumor, the previous core typically showing a fibroadenoma, and this occurs in 20–30% of Felodi's tumor. And as I say, the main reason for this is heterogeneity. So Felodi's tumor that has fibroadenoma-like areas, and I think it's very difficult to avoid these false negative biopsies. Looking at it the other way around, if your core diagnosis is fibroadenoma, the chance of the later excision being Felodi's tumor is about 1%. So the risk is very low. So I think when reporting a core biopsy of a fibroepithelial lesion, you need to have a balance between trying to pick up Felodi's tumor and having too low a threshold for reporting minor changes and therefore excising a lot of fibroadenomas. So if we diagnose a cellular fibroepithelial lesion, in our experience, repeat core is not useful. Get on and excise the lesion. So the B3 is a categorization we use in the UK. So in terms of the features which we discussed at our multidisciplinary meeting, these are the indications we use for excision. So if Felodi's tumor is in the differential, if a lesion is rapidly growing, we did a recent audit, which is present in this 2022 publication. We found that was a very useful discriminant, particularly in the era when fewer core biopsies or fewer excisions are being done. If the radiologist was suspicious, if they saw septi, or if they wondered about whether it could be malignant, we would recommend excision. Obviously, if the patient wants it removed, age is of little value because even though the average age for Felodi's tumor is older, if you consider a woman of 60, even at that age, fibroadenoma is still much more common. Similarly, size is of limited value. The average size of Felodi's tumor is larger, but if you take a 30mm lesion or 40mm lesion, still the majority are fibroadenomas rather than Felodi's tumors. So that's our approach, which we use in the multidisciplinary meeting. So thank you for your attention, and I'm happy to try and answer any questions you have.
Thank you, Dr. Lee. I think that we have a question from Pratibha in the chat box. Do you have access to that, or you rather?
No, perhaps if you could ask the question on behalf of
rare lesion, but do you ever make a diagnosis of periductal stromal tumor? WHO mentions that these are considered a subtype of phyllodes. That's a question. So a question about periductal stromal tumor.
I think I've seen 2 or 3. I think there are lesions that could be called periductal stroma tumor. I would agree with the WHO approach. Essentially, I think it's a variant of Felodi's tumors. I think the original series that was published, some of them recurred with Felodi's tumor. Both of them are CD34 positive. I think the difference is that with a periductal stroma tumor, you have essentially islands of stroma with a round gland in the middle, rather than the leaf-like architecture. But you can see intermediate lesions between that and Felodi's tumor. I think one of the flaws with that paper is that they also talked about a benign variant of that, a periductal stromal hyperplasia, but the paper doesn't actually have any pictures of it. So it's actually very difficult to know exactly what they mean by that. The paper by Tabasoli, I can't remember the first author. So I personally think it's a variant of Felodi's tumor, so I would agree with the WHO approach to that. And I think I would manage it in the same way. I would recommend excision.
I think there is another question in the chat. When would post-op radiation be performed for Felodi's tumor at your center?
We might occasionally consider it for a malignant Felodi's tumor, particularly one that's recurred. But I think the main avenue is surgical treatment. Sometimes they get systemic treatment, but I don't think there's much evidence that chemotherapy, for example, is very effective, sadly. So one of the cases I mentioned, unfortunately, has had multiple recurrences despite, I think, systemic treatment and radiotherapy.
There is another question that someone is asking: what is the approach to multiple fibroepithelial lesions on a biopsy? How often do you suggest to rebiopsy? And if there is any difference in prognosis for multiple fibroadenomas?
I think if in the UK, we may have a slightly different approach. I don't know how legalistic Canada is compared with America, or the US, I mean. But I think if the radiologist is happy and the clinician is happy and it's a woman under 25, they frequently won't get biopsied. If it's already been biopsied and the fibroadenoma has been diagnosed, if there's no change in size, our radiologist wouldn't usually biopsy it. If there's a significant increase in size, then I think they would consider biopsying it. Because certainly one of our previous studies, we found that some of those did turn out to be Felodi's tumors. If there are multiple lesions, particularly if they're large, we would biopsy them. But I don't think there's a particular increase in risk with multiple fibroadenomas. And you do occasionally get some women who have both fibroadenomas and Felodi's tumors.
Thank you. I think there is another question. Are re-excisions performed at your center to obtain 1 centimeter margins for borderline or malignant phylloides?
When I first started in Nottingham, so over 20 years ago, we used to re-excise all of our Felodi's tumors, including benign, and try to get a centimeter margin. I think, as I say, there's no clear consensus on what an adequate margin is, but I think for a borderline and malignant, we would try and get at least a few millimeters. That sounds vague, but certainly if it was at the margin or within a millimeter of the margin, we would recommend re-excision. Most of our benign Felodi's tumors are not re-excised, even if they're at the margin in the additional diagnostic surgical excision. If it recurs, then we would recommend excision with a margin on that, for the recurrence. But I think, I'm sure your national guidelines may be different, and they may be more akin to the US, which has a more different medical legal approach, I think, from ours, I suspect.
I think that in Canada, the practice vary among centers. So for example, in our center in Sunnybrook, I think that there is a discussion on a case-by-case basis with a patient, as well as in a multidisciplinary tumor board. And definitely for benign phylloides, there is no going back. For borderline, it depends on the risk tolerance, as indicated by the patient.
I think we would re-excise borderline because we're worried about those.
Yeah.
As well, obviously malignant as well, yes.
Yeah, sure.
If it was going to the margin.
And there is one more question. How do you report tumor that only focally has higher grade feature? Sorry,
could you say that again?
How do you report tumor that only focally has a higher grade feature? With a focal high grade feature.
In a surgical specimen, I think there's an element of judgment about it. And I think that's where we use the wriggle room that I talk about in our Nottingham criteria. So, and also that's often, I think it depends how extensive it is. I think if you've got a focal area, my approach would be to go back and sample it more thoroughly and try and push it into one of the other categories. And also the other thing is that, as I say, we have lots of consult cases with Felodi's tumours. These ones where we have difficulty categorising, these are the ones where I walk down the corridor and show various other people. So we try and get a consensus on how we categorise them. And often there's no right or wrong answer. But often we write in the report, 4 people have looked at this, 3 people call it this, 1 person calls it that, and we would then communicate that uncertainty at the multidisciplinary meeting. So we might therefore push for re-excision rather than not if we're not so sure. But if it's at that benign Felodi's fibroadenoma borderline, we would still not excise it. So it's at the higher grade borderlines or margins that we would use that.
So I was the one asking that question because we had a couple of cases like that, and we struggle how to report. And then I usually report, benign phylloidy focally with a borderline feature. But then when it comes to the margin, then I try to say, okay, the stuff at the margin is benign, and the borderline is however millimeter or centimeter away from the margin, and our surgeon hates that.
but unfortunately,
but that's the reality.
Surgeons like nice, clear-cut answers, but the real world isn't clear-cut, is it like that?
Yeah.
So I think, as you say, the multidisciplinary discussion, I think, is key for that. And also the woman's attitude to risk. If you've got a benign lesion with a focal area borderline well within the lesion, not at the margin, then either re-excision or watch and wait are both reasonable policies. And I think you have to discuss that uncertainty with the patient.
That sounds great. I think there are a lot of similarities between Canada and UK, definitely. And how
well, I'm sure you're nearer us than America or US. By that I mean the US.
We belong to the Queen. We're under the Queen, so we're.
Yeah, well, yes, well, I'm not going to talk about empires and all that sort of business. My mother grew up as a subject of the empire in Sri Lanka, so. Yes, anyway, ancient history. Okay.
Dr. Lee, I really want to thank you for the great participation. I'll pass it to Jessie to say maybe another couple of words to you. You're more than welcome to stay with us, and a lot of our people will be presenting cases, so if you stay, we'll be more than grateful to hear from you. Jessie, I'm passing to you.
Thank you very much for the opportunity to talk to you.
Thank you.
So up next is Dr. Farnoosh Tayari from William Osler Health Systems. So would you like to share your screen so that?
Sure, I'll just do it. Can you see it? Can you hear me?
Yes. Yeah.
Okay. So I just have to put it on the slide. No. Hold on. I practiced this before. Why is it not working now?
You can go to the bottom of the PowerPoint.
Right?
Yeah, there we go. Yeah.
Okay, got it. Okay, thank you. Hello, everyone. My name is Farnoosh, and I'm from William Osler, and I'm presenting a case that is a 55-year-old female, which by OBSV screening, they discovered that she had a mass at 6 o'clock, which was wider than tall. It was 2.8 centimeter on ultrasound. And clinically, it was at 5 o'clock, palpable, but they said it was somewhat deep. It was a fibroepithelial lesion on core biopsy. I don't know, fortunately or unfortunately, I'm presenting this because Dr. Lee nicely explained my take-home message, but I'll just go ahead. And I think that it's always good to see another example. And also, I'll try to focus more on some practical issues. Anyways, it was resected, and grossly it was unoriented, and it was 3 centimeter in maximum dimension, and it was submitted in total. So from the low power, as you can see, it's a fibroepithelial lesion, which shows increased stromal cellularity and the leaf-like structure. And then when you go higher, you can see that there are some really atypical cells here. And we had mitosis. You can see, I think there were 2 mitoses in this one, if we can see it. At least one of them is there. And then there were areas that we saw this adipose tissue. And even from this power, you can see it's a bit septated, and there is pleomorphism in size and shape of the adipocytes. And then there are some cells like this that look atypical. They look like lipoblasts. We have more of them here, cells with enlarged hyperchromatic nuclei that the nucleus is appearing indented. This is a better view of it in a higher power. So as you remember, in overall, the liposarcoma in the body, it could be a well-lived, which can turn into a dedifferentiated liposarcoma, and these guys are MDM2 amplified. We also have another type, a totally different, molecularly and morphologically different type of liposarcoma, which is called myxoid. And these guys have actually translocation 1216 and 1222, which is post-CHOP and EWS CHOP. And then there is a rare type of liposarcoma, which is pleomorphic liposarcoma, which is the most aggressive type of it. And then Dr. Lee nicely explained how we classify Felodi's tumor. So I wouldn't go over that, but up to 2000, before the last edition of WHO, traditionally, if we saw well-differentiated liposarcoma, we would call it malignant because it's a malignant heterologous element. But in the new edition, they decided to say, based on the evidence, that the metastasis, these guys that solely have well-differentiated liposarcoma and no other features of malignant, they have a low metastatic rate, and the study did not show MDM2 amplifications there. So it's been recommended that we diagnose malignant Felodi's tumor, not solely based on the findings of a well-defined liposarcoma, and we should look at the other stromal features. In WHO, they also talk a little bit about, like, one line about pleomorphic sarcoma that could be more, could have more adverse outcome. And about the myxoid, there are some reports, but which we don't know if they are really true myxoid liposarcomas that we see in other areas. So our diagnosis was for this tumor, we called it borderline, with at least, which was at least 3 centimeter in maximum dimension. And we, in the comment, we said that there are heterogeneous increased cellularity, there's diff-like architecture, there's atypia, there were up to 5 mitosis per high power field, and there wasn't any stromal overgrowth or necrosis. And we said that there is a well-differentiated liposarcomatous component here. And we recommended a re-excision with at least 1 centimeter margin. And this is one of the papers that shows that there's no MDM2 amplification. So as you can see in this picture, this is negative, and this one shows a coordinated gain of CEP12 and MDM2. So there are breast lesions that have fat components. So among them, I have put examples here. This is the list, and then I just quickly go through the pictures. This is a mammary hamartoma. We can have a lipomatous variant of myofibroblastoma. Excuse me. This is the breast lipoma. We can have spindle cell lipoma of the breast. This is angiolipoma of the breast. And this is the periductal stromal tumor. which also can have this lipomatous component. Metaplastic carcinoma with heterologous mesenchymal differentiation also can have it. And here, as Dr. Lee explained, DCIS and immunos can be really helpful. And yes, we do have primary breast well-differentiated liposarcoma. This one was proved by molecular studies that it had MDM2 amplification. And also, I wanted to talk about mimics of lipoblast. So this is just the list, and I will show you the pictures. So we have Lockern cells. It's a German word, which means a hole in the nucleus. So we frequently see them, especially when even normal fat has been thickly sliced, sectioned, and we can see them in benign lipogenic tumors. They're never hyperchromatic or pleomorphic. We have some multivacuolar histiocytes when there is fine body granulomatous reaction, for example, injection with silicone, paraffin, and other agents. Brown fat, they have nuclei that are usually centrally located or slightly eccentric. They have this lacy cytoplasm, and often the nucleoli here is prominent. And yes, they are positive for UCP1, but so are lipoblast. So this could be a pitfall. There are pseudoliboblasts that contain mucin in a variety of myxoid tumors like myxofibrosarcoma, myxoid inflammatory fibroblastic sarcoma. And unbelievable that signet ring-like cells can be seen in many lesions, from carcinoma to lymphoma to melanoma, and even benign melanocytic nevi. Looking for these cells, even I was very impressed when I was looking at the list. And beware of atrophic fat that could look like a little bit atypical and maybe like signet rings. Fat necrosis, they can have some histiocytes in them that could look like lipoblast. And this is just a fixation artifact. I believe this one was just a squamous cell carcinoma, and this is the frozen section. So there's no adipose tissue here at all, and this is just a fixation artifact. So in summary, I just wanted to talk about Felodi's tumors that have a well-differentiated liposarcomatous component. We should not call them malignant just based on that. I talked about differential diagnosis of breast fat containing lesions and the mimics of lipoblast. And thank you very much.
Does anyone have any questions or comments?
Anush, maybe you mentioned that, but I missed it. What was the diagnosis on the core biopsy of your case?
It was called a cellular fibroepithelial lesion.
Okay, if not, thank you very much. We'll move on to the next presentation. That's from Dr. Padita Inyangar from Credit Valley Hospital. So you can share screen for us. Thank you.
Yeah. Hi, can everyone hear me?
Yes.
Okay, great. I'm trying to show scanned slides, so I hope it'll work. Can you see my PowerPoint, Jessie?
Yes, yes.
Okay. So I'm not presenting any unusual diagnosis. I'm just presenting routine cases where the targeted lesion was benign, but focal atypia was incidentally found within these lesions and created a bit of controversy within the department on how to report these. I have hopefully 3 quick cases. I'll start with the most straightforward one and go to the most controversial one at the end. The first case is a 45-year-old woman who presented with a palpable lump in the left breast. It was a 2.2 centimeter nodule, both clinically and radiologically thought to be a fibroadenoma. She had no past significant history. And the core biopsy was called a sclerosing lesion with atypia. And because of the atypia that was found, an excision was performed. And then in the interest of time, I'll just show you the slides from the excision. Are you able to see my slides?
Yes.
Okay, great. So you can see on low power, it was quite a complex proliferative lesion. Not sure if there's what the best term for it would be, whether it be a complex sclerosing lesion, but there were areas of adenosis, sclerosing adenosis. I'll just kind of go around to show you the lesion. Columnar cell change, there was fibroadenomatoid change, areas that resembled an intraductal papilloma. It was quite busy lesion. And there was proliferation. Some areas that look like this look more like usual ductal hyperplasia. But the area of concern was this area, which showed quite significant nuclear pleomorphism. So there's moderate to marked nuclear pleomorphism and readily identified mitotic figures, as well as necrosis. Some of us felt that this lesion also had a bit of apocrine features. I'm not sure if everyone would agree. But because of the marked pleomorphism, we were leaning more towards the diagnosis of DCIS. The issue with the case was this lesion was quite small. So I hope the ruler will work. This lesion just measured over 2 millimeters. And it was clear of the margins in the sense that it was over 2 millimeters from the closest margin. So this discussion that's raised at a tumor board was, it's a small focus, 2.1 millimeters of high-grade DCIS within a complex proliferative lesion. And the issue for the radiation oncologist was that given this was the left breast, the patient was relatively young at 45, and this was a small volume of DCIS. The issue that was discussed was whether the benefit of radiation outweighed any risks given left-sided and any heart disease implications in the future. In the end, the patient did opt to get radiation treatment, but it was just an interesting case for us on how to deal with a small volume of DCIS. The next case I have goes to the other end of the spectrum where I think it's more difficult, where we have low-grade atypical lesions. This was a 25-year-old female who presented with a palpable lump in the left breast. It had been present for a few years, but was now causing discomfort. And the core biopsy was called Fibroadenoma, and the patient opted for an excision. So you can see on low power here, it's, we thought this was a fibroepithelial lesion. You can see the myxoid stroma. Doesn't have the classic intracanalicular pattern, but there were areas with the sclerosing adenosis, and some people may term this a complex fibroadenoma. The area that was concerning for us where there was these few ducts showing this low-grade cytologic atypia with some monotony, perhaps not the best polarization, but maybe the start of some polarization. So there was one duct like this, and then there were ducts here, which showed some similar features with monotony and attempted polarization. Between these two ducts, there was also this kind of long duct here, which not everyone agreed whether this was atypical or not, but there was some micropapillary tufts. And I'll show you the immunostaining. And I should mention that this atypia was found within the lesion, and there was no atypia seen in the surrounding breast. So this is the Ck5 staining. The slide just got rotated, so I'll try to match it. So you can see this is the first duct that I showed, which I hope people agree did show some low-grade atypical features. There's an absence of Ck5 staining. Here's that long duct that we saw. There's some loss, but there's also some mosaic pattern for Ck5. And here are the other ducts that you see here. A little bit of loss here, but also some retained Ck5 staining. The ER the ER also showed some overexpression in those atypical ducts. Here's the long one that we saw, and then this end. The controversy it raised within our department, and I'd be interested in knowing what the audience thought, was whether we should measure across this area, whether this would qualify as low-grade DCIS, as it would be over 2 millimeters, or whether these are scattered ducts and best considered as atypical ductal hyperplasia. In the end, my colleague who sent out the case called it fibroadenoma with ADH, and mentioned this was again discussed at tumor board. Since there was no atypia found in the surrounding breast tissue, they decided to simply watch this patient as she's quite young. So be interested in knowing what the audience, how they would approach such a lesion. And then my last case that generated more controversy was in an even younger patient who's 21 years old, who had a palpable mass that was 2.2 centimeters. It was called a fibroepithelial lesion with increased stromal cellularity. And I'll show you the pictures from that. So this is a bit probably an easier example of a fibroadenoma on low power to recognize. And I'll just go to the areas of interest since I don't want to take up anyone else's time. There was this epithelial proliferation, which again showed this low-grade monotony with an attempt at polarization. And these areas were scattered throughout the lesion. And again, this raised difficulty on how to measure this atypia. Would you measure across, or would you consider them scattered foci of ADH, or would you consider this low-grade DCIS? So I'm trying to show you throughout the lesion, these areas. The ER staining. So here was the first area that did show overexpression of ER. And again, you can see that it's scattered throughout the lesion. And the Ck5 was lost in these areas. So this patient was only 21 years old, and apparently she had quite a small breast. There was no atypia again seen in the surrounding breast. So the case was discussed at tumor board, and they recommended getting an MRI on her and possibly referring her to genetics. Genetics, because it had only been called ADH within a fibroadenoma, declined to do the testing that was done by the province, covered by the province. So the case was sent out for external consultation. In one hospital in the GTA, it was called intermediate grade DCIS arising within a cellular fibroadenoma. This was again discussed at tumor board. I'm not quite sure why, but they decided to send it to another consultant. And this time it was called ADH within a cellular fibroadenoma, and this was quite an experienced breast pathologist. The interesting thing is, because of the diagnosis of DCIS that was made, she ended up getting the genetics done. MRI had only shown extremely dense breast tissue, and there are no other lesions of interest. And interestingly, she didn't have a BRCA mutation, but she did have a pathogenic variant in the Ck2 gene. And this is considered a moderate risk gene, which confers a lifetime risk of 25 to about 40%. And this is a slight increased risk for colon cancer. So what they've opted to do is put the patient in for high-risk breast cancer screening, which is eligible when she's 30. Right now, she's only 21. Chemo prevention is unclear in patients with this Ck5 mutation, and prophylactic mastectomy is not recommended. And colonoscopy is recommended every 5 years. So that's where she's at now, where she's just had the excision and she's being closely followed. So I just thought these were interesting cases that generated controversy within our department and also got varied opinions on external consultation. Thank you.
Thank you, Pratibha, for bringing these very interesting and very challenging sounding cases. Does anyone in the audience want to kind of have a say about what they, if they kind of concur or disagree with the final diagnosis?
Could I say, Jessie, I would agree with your original diagnosis. So DCIS, ADH, and ADH. And also what we were always taught was that in fibroepithelial lesions, your threshold for calling something DCIS should be higher than in the normal breast, which is why I would favor ADH for the second and third one. And there are other circumstances, for example, gynecomastia, again, the threshold is higher than normal breast.
I was just going to agree, Pratibha, on the first two for sure. I mean, it was very limited in the first example you showed, but with that degree of cytologic atypia and necrosis, we don't obviously consider size too much when you are dealing with, excuse me, higher grades of atypical introductive proliferations. And the second one, I would go ADH on that one for sure, even though it did look like it was at least partially getting into the duct, but it wasn't contiguous. And I think it's better to err on the side of the less diagnosis than a more aggressive one. And the final one I struggled with a bit. I don't know if I was seeing enough of the areas, and probably ADH, but not more than that, I would say. But I guess what I was thinking more is definitely even atypia. A lot of the lining was columnar, and I think it's hard to interpret any immunos in that setting. But I think in the last field you showed, I thought there was probably some architecture that would push me, but certainly not more than that.
Are there any other questions? If not, thank you very much. And we'll move on to the next presentation by Professor Sharon Nofech-Mozes.
Okay, let me just share my screen. I'm not sure that I'm sharing the right screen. Do you see the two screens, or am I in the right?
I'm just seeing the folders now.
Sorry?
I'm just seeing the folders, or now it's Excel
it's an Excel.
Yeah.
Okay. So I'll just okay. Let me just hope that it will go now. Yeah, I think it's fine, right?
Yes.
Okay, sure. So I really wanted to go today over some issues that are related to DCIS with the microinvasion. This is going to be a focused presentation and it's going to last a little bit more than 10 minutes, and I'm sorry for that, but hopefully it would worth it. So oftentimes we have issues when we review cases in consultation service and also our in-house cases when it comes to DCIS with microinvasion. So we all know that the definition of microinvasion is stromal invasion that is less than 1 millimeter. And it sounds really simple, but many times we ask ourselves if we can make the call even without immunohistochemistry. And I also want to highlight the advantage of using a cocktail immunohistochemistry if it's available, to discuss the differential diagnosis between microinvasion and displacement, and maybe briefly talk about ordering biomarkers in pure DCIS, as well as in DCIS with microinvasion. Also, whether we can actually do any multi-gene assays on these cases. And last, I want to talk about the importance of reporting the number of foci of microinvasion and why it has clinical significance. So let's start with an obvious case of high-grade DCIS with areas of periductal lymphocytic infiltrate. These areas are often associated with early stromal invasion and need to be looked at really carefully. So on higher power, there are a few irregular epithelial nests without recognizable myoepithelial cells in the green circle. These are obviously invasive, and in my opinion, they can be called microinvasion without immunohistochemistry. On the right side, within the yellow circle, there are some nests with smooth borders and fairly visible myoepithelial cells, and delineated very well a defined basement membrane. And those we could probably classify as DCIS, lobular cancerization, without the need to do immunohistochemistry. And then there is on the left, in the light blue circle, there is a bit less obvious lesion. On one hand, it is fairly round. On the other hand, there is no obvious myoepithelial cells. And in isolation, this focus may require immunohistochemistry. But in the context of unequivocal microinvasion, even if we just spend the whole thing, we're still within the limits of microinvasion. So for this case, I did not order immunohistochemistry. Here is another case. At low power, it is obvious that there is high-grade DCIS with several distended ducts and dense lymphocytic infiltrate, focusing on the region of interest. We see some small nests budding out. We received this case for review together with myosin immunostain. And on low power, you can actually see that if you just look at the case at low magnification, it appears to be intact or myoepithelial cells retained. But in fact, if you're not using an IHC cocktail, you need to look at those slides really, really careful and at high power, because if you have single cells or very small nests, they are often being missed on a scanning magnification, because it's hard to figure out those cells, particularly if they are placed in an area of dense inflammatory cell infiltrate. This is another case of high-grade DCIS, and like the other cases, is associated with dense lymphocytic infiltrate, in this case, even well-developed germinal centers. And in these cases, when you go into the areas of interest, there are obvious areas of microinvasion. But if you are using a cocktail that includes both myoepithelial cells and a keratin, you can actually see that you can identify more than meet the eye, and there are single cells scattered. So this will help you to actually identify the extent of disease. Let's move on to a different scenario. In this case, there is DCIS of low to intermediate nuclear grade, and it involves an area of sclerosing adenosis. And when DCIS involves sclerosing adenosis, we are always a little bit nervous. We oftentimes are triggered to think about stromal invasion just because it looks a little bit irregular. However, on low power, you can actually see that the lobular pattern is preserved, and on a high power you usually are able to identify myoepithelial cells on H&E, and in my experience usually you don't need immunohistochemistry, but if you do, like in this case, we received that case for consultation, and this was done elsewhere. It looked like a myoepithelium was retained everywhere. So let's go back to the same slide, but now focus on a different area. As you can see, there is a nest of epithelial cells away from the DCIS, and this nest is situated in an area of stromal fibrosis. And on higher power, the nest is surrounded by a space. So let's think what is the differential diagnosis for this area. Is that DCIS with retraction? Is microinvasion? Is that LVI, or maybe just displacement? And in fact, as I said, this case came with the built-in stains. So the myosin P63 cocktail showed no myoepithelium around this focus of interest, but D240 was positive. Yet I actually favored it to be displacement, because the overall the nest was in a place of linear fibrosis with inflammatory cells, some hemosiderin deposits, and I felt that it's unlikely to represent a true lymphovascular invasion. This case was actually more interesting than just that. Here is yet another slide from the same case. And we can see here that there are two prominent lobules where on top of sclerosing adenosis, there are atypical cells. And on higher power, we can see that this type of low-grade atypia with abundant cytoplasm is very similar to the morphology of DCIS that we've seen before. But there is also an area where there are some tubular structures that started to be angulated and a bit breaking apart, becoming very irregular with a little bit of stromal changes. And in fact, when you look at this area with the P63 myosin cocktail, you can see that these angulated and irregular tubular structures were lacking myoepithelium. So using the micrometer, this is just over 1 millimeter. So we have here early stromal invasion, and obviously it makes you even more nervous about that area of possible LVI that I decided to call displacement. So the fact that we have here angulated structures, single cells, and lack of myoepithelium is supportive here of stromal invasion in this area. It was quite subtle. Now I want to move on to talk about the issue of biomarkers testing. So recently, Ontario Health approved funding for ER testing in DCIS. However, the announcement was a little bit vague with regards to when to order this this test. So biomarkers are really relevant in pure DCIS after the lesion is excised, because in 20 to 30% of cases, there will be an upgrade to invasive carcinoma. So in such a scenario, we don't care about the biomarkers or ER in the DCIS component. We want to know the profile within the invasion. So do not order ER on the core biopsy unless there was an excision and there is no residual DCIS. We also need to understand that the main benefit from adjuvant endocrine therapy is limited to postmenopausal women with 2 breasts when it becomes to DCIS. So it is really almost irrelevant in women who had mastectomy, particularly bilateral mastectomy. So for bilateral mastectomy, I practically never order ER. And with a unilateral mastectomy, I usually put a comment to say that I can do it upon request, and I was never requested to do that. So for microinvasion, you need to really know the practice in your center. So in Sunnybrook, we test HER2 upon request if there is but if there are multiple foci of microinvasion, we tend to reflex and report HER2, particularly in young patients, because our clinicians may end up prescribing systemic therapy to these patients. And last, I would like to share findings from one of the DCIS studies that I took part in. As part of the Ontario DCIS studies, we performed retrospective population-based analysis and looked at the significance of finding DCIS with microinvasion on patient outcome. And as you know, the current definition of microinvasion is not distinguishing between a single focus of microinvasion and multiple foci of microinvasion. And the number of foci of microinvasion are actually not routinely reported, not in the CAP or in the ICCR system. For our analysis, we looked at the clinical outcome of almost 3,000 cases of DCIS that were treated with breast-conserving surgery or lumpectomy. 2,721 patients had pure DCIS. Half of them got radiotherapy, and 267 had microinvasion, and of those, 58% had radiation therapy. So in multivariable analysis, the presence of multiple foci of microinvasion was associated with an increased risk of invasive recurrence, but not with in situ recurrence. Let's focus on the lower half of the table here. We will look at the outcome of patients that received lumpectomy alone, lumpectomy in radiation, and lumpectomy in boost. And we can see that at 15 years, 74% of the patients had a recurrence-free survival if they received a lumpectomy alone, and this number ended up being 95% if patients received adjuvant radiation with the addition of boost radiation. So overall, we concluded that the presence of multiple foci of microinvasion in DCIS is associated with higher 15-year risk of invasive local recurrence after breast-conserving therapy compared to women with pure DCIS, but the treatment with whole breast and boost radiation can mitigate this risk. So overall, to summarize our little focused conversation today, it is possible to call microinvasion without immunohistochemistry whatsoever, but if possible, use cocktail that includes keratin. And if you're using either P63, myosin, or any other myoepithelial cell marker in isolation, examine carefully on high power. And in difficult cases, when you're suspecting single cells, ask for a separate low molecular weight keratin and keep the same orientation, because every time the morphology is changing and on deeper section it's hard to follow. Consider the possibility of displacement when the region of interest is close or within a biopsy site or a scar. And most importantly, not all foci of microinvasion need to be confirmed by IHC. Some can be called by H&E only. For biomarkers, for pure DCIS, order ER on breast conserving surgery specimens. You can put a note that ER can be tested upon request for mastectomy, particularly bilateral. And when there is no residual DCIS on excision, you can order it on the core, but then underscore on your requisition the circumstances. And for DCIS with microinvasion, it's best to know your oncologist practice. In our practice, we do HER2 upfront when we have multiple foci of microinvasion. And we put a note that HER2 can be tested upon request for single focus of microinvasion. And last, DCIS with microinvasion is insufficient for Oncotype DX, blueprint, or MammaPrint, because those will need 2 millimeters of a invasive tumor in order to be able to give you a score. And please report if you see more than one focus of microinvasion, because your radiation oncologist is likely to add a boost. This is it.
Well, thank you very much, Sharon. That was very informative, and it sounds really challenging, actually. that call about the kind of the displacement of the tumor cells. I don't know if I have the guts to do that, but I wonder what everyone else thinks.
So thanks, Sharon, that was great. I guess I can comment on our own practice at UHN, and at least my own practice when it comes to ER testing on DCIS. So I don't order it at all on any specimen unless requested. And I could say I get a request maybe once every 3 or 4 months to do it, because our clinicians don't necessarily treat these patients with endocrine therapy. So it doesn't delay anything when I get a request, and I save a lot of time, I think, and money. So that's certainly the way we've been practicing, and it hasn't raised issues. Personally, I don't order HER2 on microinvasion, and I don't think I've ever been asked to do it, but I certainly see the value of doing it when there are multiple foci. And that would be my comments regarding biomarkers. In terms of Jessie's question about the displacement versus lymphovascular invasion, I completely agree with Sharon's interpretation. You can see, I think the core biopsy site changes there. And I think the DCIS did have a papillary architecture to it, which is the type of lesion that you're going to see epithelial displacement in. It's, you know, that's the most common lesion when you see it. So I completely agree with Sharon's interpretation, although she did throw in a little bit of a, you know, a challenge with the second slide that she showed from that case. So yeah. And I'm always very envious when I see consults for all those labs that have cocktails for keratins and myoepithelial markers, because we do not. But I do always throw in a keratin when I'm looking for microinvasion, because at least it draws my eye to the lesion of interest, the area of interest.
Thank you. I see that Dragona is asking how many foci of microinvasion will make the difference. So in our analysis, we compared one versus more than one, just because the numbers are getting smaller and smaller if you are going to do 3 or 4 and so on. So we just did one versus more than one. That's the answer for that.
Sharon, there's another question, not comment from Pratiba. We have gotten more requests for your R&D sales during the pandemic, as not all the patients went to surgery in a timely manner.
Yeah, I mean, during the pandemic, we did a lot of things that were just to keep the ball rolling on these patients while they were waiting. So I think that this was reasonable at the time. But I think that now we are pretty much with the full capacity of OR, and the backlog is no longer, I think, existing. So I don't think that we need to do that, and it's unlikely that patients will be given endocrine therapy prior to surgery now that ORs are open.
And also, I think that case that you showed for microinvasion and the sea of sclerosing adenosis, that was really challenging, that you could really identify and spot it on. I find that was really challenging to see it, even when you showed it so closely. May I take 1 second, just congratulate Sharon on becoming a full professor at the University of Toronto, and we're really, really fortunate to have you with us, and sincere congratulations from, I'm sure, from everybody that you see on this screen, from all 60 people.
Thank you.
And we can move forward.
All right, our next speaker is Dr. Elena Bochkari. Sorry if I butchered your last name, from Windsor Regional Hospital.
Hi there, I'm Alina, and no worries. So I have an interesting and at the same time was a challenging case for me. So I am sharing the struggle I had with that. The clinical presentation, can you hear me loud and clearly so I can?
Yes, absolutely. Fine.
Okay, perfect. So the patient is a 46-year-old female who was referred to a surgical consultation because she noticed 2 left breast masses. The first mass was noticed a year ago, and the second mass 6 months later, and according to the patient, have increased in size. She mentioned that there is no redness, swelling, pain, trauma, or nipple discharge. There is no prior breast pathology. However, she had bilateral breast implants. On physical examination, the surgeon described that there is a slightly lobulated mass tethered to the skin, but not fixed to the chest wall. And the patient was followed up with ultrasound in 2 occasions. And both ultrasounds identified the 2 masses. The most recent one measured the largest mass being 1.7 centimeter and the second mass 0.6, and these masses were adjacent. The radiologic impression was a little bit confusing in terms that initially was thought there is a benign fibroadenoma, and the most recent ultrasound interpretation radiologists felt that is a sebaceous cyst. I have attached the ultrasound, and I can see why they would think there is a benign lesion, taking into account that the borders are quite smooth. So there was no prior biopsy, and between the surgeon and the patient, the discussion was that better will have excision, and all at the same time hoping for treatment. So we received 3 unoriented tissue fragments with size variable between 4.5 to 2 centimeter, and each fragment showed described nodules that had a homogeneous cut surface, and these nodules are abutting the edges of each tissue fragment that we received. So we decided to ink them and submit it in toto. I do not have those pictures of it, so then I'm moving just to the H&E. This is one fragment where you can see that the lesion is involving the ink margin, and this happened in every section that had the periphery of the tissue. Therefore, we assume that whatever lesion is this is involving the surgical margin, even though this wasn't received as an oriented specimen. As you can see, it's quite cellular. It's infiltrating the fat. There are a lot of vessels, but those have a narrow lumen and thin wall. And there was no staghorn appearance of those vessels. In other section, a higher power, you can see that these spindle cells, they have a short fascicle or storiform appearance. You can appreciate the entrapped adipocytes and scattered small vessels. On another area, there are some collagen bands at the periphery of the lesion. You can appreciate that it's quite cellular, hyperchromatic, and again, the infiltrative margins of this lesion. On another areas, there is more myoid differentiation, in some areas focal myxoid. So it was heterogeneous, but the same theme, spindle cell neoplasms that appear hyperchromatic on a low power. On a higher power, in some areas, there is a transition from the storiform pattern to the more fascicular pattern. And that's a subtle change that I didn't appreciate initially, but now when the case was all put together, made a lot of sense. So you can appreciate that in hotspot areas, there are mitosis, and there are up to 16 mitoses over 10 high power field. Again, this somehow fasciculate appearance of the tumor in some areas. So then just to summarize the morphology of the lesion, this is a cellular spindle cell neoplasm with storiform and focally fascicular or heribone and myoid differentiation. There is infiltration into adipose tissue. There is moderate nuclear atypia. Mitosis were count up to 16 mitoses. There is no tumor necrosis, no epithelial elements or entrapped breast ducts or acini. And that was a good thing to pay attention because it seems to be a superficial lesion. We started with a large panel trying to rule out a metaplastic carcinoma, fibromatosis, solitary fibrous tumor, DFSP, or any other vascular or neural origin spindle cell neoplasm. And I'll show you just the positive staining that we had in this lesion. Interestingly, beta-catenin appeared to be positive. However, in a higher power field, you can see that this is more cytoplasmic. There was no nuclear staining, so it was considered a non-specific staining pattern for beta-catenin. When it comes to CD99, there was some patchy staining. SMA was staining, especially the myoid component or the myoid aspect and the vessels. CD34 had an interesting pattern. The main lesion seems to be CD34 negative. However, at the periphery of the lesion, you see an intense staining. And this is something, again, I have to acknowledge, I didn't pay attention initially, but it would make a lot of sense when we'll find out what is the diagnosis for this lesion. For the purpose of this presentation, I did CD34, which I didn't do it on the initial run. And it seems that whatever lesion is there is at least focally or partially positive for CD34. So just to summarize, the immunoprofile of this lesion is that all the keratin stain were negative, S-min was negative, S100 was negative, Soxten, ER, and other vascular markers. The only positive stain that we had, it was BCL2, CD99, SMA, and CD34 with an interesting pattern at the periphery. And beta-catenin was considered cytoplasmic. So the differential diagnosis for a CD34 positive tumor will include solitary fibrous tumor, dermatofibrosarcoma protuberance, epithelioid hemangioethelioma, or something else. And for the most three common entities that are CD34 positive, in order to differentiate them accurately, you need some molecular testing. So then we decided to send the case out with a preliminary report saying spindle cell neoplasm extending to the surgical margins. So the molecular studies show that there is a COL1A1 PDGF gene fusion And the final diagnosis is fibrosarcoma X dermatofibrosarcoma protuberans. The diagnosis of fibrosarcoma was made based on the particular fascicular growth pattern, moderate nuclear atypia, and the increased mitosis. So my take-home message and the lessons I learned with this case is that it's preferable to perform IHC on different sections when you see different morphology. The fact that some lesion you are expecting to be CD34 positive, if you don't elicit that staining, most likely, or at least you should consider that that might be a fibrosarcomatous transformation. In terms of morphology, that may indicate a transformation into fibrosarcoma is the fascicular or herringbone pattern. And every time when you have an increased cellularity or increased mitotic activity and mitosis, that tells you there is a more aggressive process. And as an interesting fact, which I didn't know, is that fibrosarcoma can arise either from DFSP and solitary fibrous tumor, which was my initial working diagnosis. So this is the end of my presentation. I hope you enjoy it.
Thank you, Elena, for bringing this incredibly rare entity to our attention. Does anyone have, oh, if I can just actually ask you to stop sharing screen for the moment. It's all right. And if anyone has got any questions that they'd like to raise.
Elena, do you think that this was a skin tumor, or was it truly a breast tumor?
So we received fragments just shaving off the skin. We don't know exactly how deep they were, but according to the surgeon, it seems that this lesion was tethering the skin. And the fact that we didn't see any breast elements in the sections, and there were quite few sections we submitted. So I guess it's pertaining to the breast, to the subcutaneous adipose tissue, but it's hard to tell. Like I think the radiologist will be the best to appreciate that. We just imply that we didn't see breast elements or ducts or terminal duct lobular units. That must be a superficial lesion.
Thank you.
Just a comment to make, Melina, because I'm certainly no expert in anything sarcoma, breast or otherwise. Just to say that, you know, Twitter isn't all bad. I was scrolling last night and a tweet, I saw this tweet that was actually talking about DFSP in the breast, and it directed me to a paper from Brendan Dixon and his colleagues at Sinai and from Boston, where they described a different fusion gene product when DFSP is found in the breast, not in all cases, but in a very small number of cases. And these showed preferential localization to those arising in breast tissue or overlying breast tissue. So that's about all I have to add, but it was very timely that I came across it last night, but a different fusion to the one that was recognized in your case.
Right, so thank you, Elena. Our next speaker is Dr. Jessie Marathi from Lakeridge Ridge Health in Oshawa. So if you'd like to share screen.
What I get this for? You have the presentation yourself?
I do, so I can do the share screen if you can.
Yes.
You can unshare, then I can do the share screen, and then you can just let me know if you want me to advance your presentation.
Okay.
If you just give me a minute.
Because I try, it doesn't work. I don't know why.
Okay, so give me a sec. Okay, can you see your presentation now?
Yes, I do.
Okay, and just please let me know if you want me to advance.
Thank you.
Thank you.
So thank you for this. I actually would like to present a case of which I saw about a week ago. And the biopsy maybe a month ago. She is 76 years old, female, presented with a palpable breast mass. And the imaging described it as a 12 o'clock position, a hypoechoic mass, which was about 2-point-something centimeter. Previous mammogram was unremarkable. So this is something like recently pop out. So the next slide, this is the biopsy, the core biopsy which we received. And as you can see, there is some epithelial tumor, the nest of cells there, obviously malignant, but we can see them on a higher power later. But then the interesting thing is the stroma in between, as you can see here, from this power, some sort of a very myxoidy, fibrous-y, myxoidy, not the usual stroma which you see in invasive carcinoma. Next. Here, another view, you can see the malignant epithelial looking cells here, and in between them, some of the stroma, which is a little bit myxoidy here, but the next one, next slide, you can see more, the stroma is really different here. It's look like a matrix appearance to it. It's some sort of a myxoid with some fibrillar, fibrous-y looking material. The next slide, we can see more of this on higher power. There's a lot of it. Sometimes you give you a hint, this could be cartilaginous or something at this stage, but it's too early to say that. Next slide. There's another one where you can see more of this myxoidy stroma around those. And so you try to do some immuno at this stage. Next slide. So you do epithelial marker, and it's positive for some of the epithelial marker, negative for others. Like this one actually was AE1, but sometimes you have to do panels of immunomarkers for epithelial markers in those tumors. Next one is, next slide.
Sorry, I'm having difficulty advancing.
Sorry to make you do some work.
There you go.
And so when you do some epithelial marker also, you can see some of them are positive, P63, and smooth muscle actin actually was also focally positive. And then when you do breast, yeah, go to the next one. The breast biomarkers, they're all negative. So it's triple negative cancer with this stroma. So next slide will give you some idea what was the thought at that time. This is a carcinoma with metaplastic or matrix forming metaplastic carcinoma possibly. And we thought the best thing is wait for the excisional, whether it's mastectomy or excision biopsy for the definite diagnosis, but that was really suggested at that time. So next slide. This is the excision, as you can see, rather well-demarcated neoplasm. As you can see here, similar morphology. Next slide. And there is the central of it is actually acellular, slightly fibrotic looking, but this is like almost zone of no cells. And then there are some cells at the periphery of it. Next slide. These are the similar tumor cell which we saw before on the biopsy, easily recognizable as epithelial cells. Next one. Here you can see those malignant cells which high nuclear ratio, and you can see some of the stroma. And the next slide. I'm going fast because I know you guys are going to run out of time. And you can see here the epithelial component with mitosis and large nuclei. Next slide. Then there's more of this stroma, which is very myxoidy and fibrous-y looking. Next slide. And then actually you go some areas where you can see some sort of transition into cartilaginous looking matrix or mesenchymal component to it. It's you can see the difference between the tumor itself and the next area where it's some sort of roundish cells with smaller nuclei and has the cartilaginous look to it. Next one. And this is more of this stromal cells, which look here at very cartilaginous looking, and tumor cells, which is at the periphery of it, which you can see some sort of a transition into this mesenchymal component. Next one. This is a higher power of this area, which resemble cartilage. Next one. This, sometimes they say this stroma or the matrix may look like a mucinous, but you can see contrast. This is from a different case of a mucinous carcinoma, And you can see this one is more of a solid and the fibromyxoid looking to it, different from the mucin. Next one. And we did the same immunoepithelial marker. Next one. I think I did this time Ck5 and was positive in this tumor, but we did a lot of markers at that time. Next slide. So this goes under the category of metaplastic carcinoma. As you know, these are rare cancer, and some people say up to 5%, but a lot of literature mention 1%. And these are expressed, there's some sort of epithelial origin and non-glandular morphology, which is the mesenchymal, cartilage, osseous, or spindle, squamous, whatever. And the subtype there is very complex. As you can see, so many categories actually go under this metaplastic carcinoma, from the low-grade adenosquamous to the fibromatosis-like, to squamous cell, to spindle cell, and the one with mesenchymal differentiation or matrix, and those sometimes with malignant mesenchymal component, and maybe more even under this category. Next. So the differential also is bigger than the list which I'm showing you, but we have to exclude other things which enter into this, even salivary gland or basal-like tumor or myoepithelial, epithelial myoepithelial tumor and fibromatosis come into the differential diagnosis of metaplastic carcinoma. Anyway, we're not talking about that because this is a broad category. Next one. So this case actually goes into this matrix forming metaplastic carcinoma, which was first described by Norris in 1989. He described it by ductal carcinomatous component with direct transition to areas with cartilaginous and osseous differentiation without an intervening spindle cell element. And they're all thinking that this is like a de-differentiation into this mesenchymal element from the same cells. Some think these are maybe differentiated from myopithelial cells. So I thought this is interesting to share it with you guys. The last slide, this is like just to say thank you. And this was actually from a case of ductal carcinoma in situ, which has a lot of samobitous looking bodies. Thank you. Could I ask Sharon, do you guys do any cytogenetics on those tumors?
We're not. No, we do the regular biomarkers, and as you indicated, those are usually triple negative. So we are not using any of the multi-gene assays. Those are preserved to luminal tumors.
Okay.
Any other questions for Dr. Jessie? No? Okay. So for our final presentation, it's from Dr. Dragana Plavadic. So sorry again, if I butcher your last name, from Lake Ridge Health, Oshawa as well. So if you could share screen with us.
Yeah, good afternoon, everybody. It's nice to see you all. So let's see how I do with my share screen. Oh, wow. Share. Oh, okay, so do you see it now?
Yes, yes, we can see your screen.
Perfect. So I'm supposed to put slideshow from the beginning. Okay, do you see it?
Yes, it's perfect. Thank you.
Okay, perfect. So I have put my email in case you have questions or suggestions. This is about the case, which was just a core biopsy. We haven't received the excision specimen yet, but we made all this brave diagnosis. So this is...
1 second, can you swap the monitor?
Okay.
It should be usually up on your screen, display settings, swap the monitor.
Swap the monitor.
If not, then continue, we won't lose time on that.
Oops, what happened now? Now we see nothing.
Yeah, it's
yeah, no, I'm not computer savvy.
okay. Let's continue.
So how are you seeing at least half of the screen or just a small picture?
No, we see two pictures, but that's okay. Let's continue.
Yeah, okay. All right, let's see. How about this?
Better.
Okay, cool. All right. So this was a 77-year-old woman who had a large mass in the left breast, and the radiologist wrote, "Please confirm invasive ductal carcinoma." So when I received this case, I look at the core biopsy. It basically looked like this, pretty much uniformly, with a little bit more details, which I will describe. And so I thought, oh, definitely not invasive ductal carcinoma. And because I kind of was rushing and didn't have that much time to analyze it the way how we will analyze it now, I just ordered a panel of markers for, as we can see, a spindle cell lesion on the core biopsy. So now in retrospect, what actually I find is that if you analyze H&E well, you can almost get to the diagnosis. Of course, you need to confirm. So what we see here is a spindle cell lesion, which is, there are a little bit different areas of cellularity, but most of them were more densely cellular. We also see that the lesion is infiltrating around the normal duct epithelial elements. And there is also a component of collagenous fibrosis, and actually in areas which doesn't kind of project that well, but it looked like more keloidal-like stroma, or some area almost like pseudoangiomatous stromal hyperplasia kind of thing. And so that was like just a general thing. The cells are more, they are spindly, they're more uniform, there is some variation, and we can see that the lesion infiltrates into the surrounding fat, and around the ductal elements, there was a little bit of lymphocytic infiltrate. So on a higher power, there was sort of this interlacing fascicles that looked like storiform pattern. And mitosis were actually very rare. So I don't know if this is mitosis or, but I found one definite mitosis. So this is what we got. And so I ordered a number of markers, but if we actually think of the differential diagnosis in these kind of lesions, we have to consider spindle cell lesions benign, such as fibromatosis or leiomyoma or schwannoma, sometimes scars, nodular fasciitis, myofibroblastoma, like, you know, very broad differential. And then there is a possibility of Felodi's tumor because we had these normal elements, and obviously spindle cell metaplastic carcinoma. So in the first slide that I took when Immunos came was a smooth muscle actin, and this is the picture of it. So this is around the elements, and the tumor was positive. So I thought, oh wow, look at that. But then all cytokeratins were positive, A1, A3, Ck5, 34 beta E12. And you can see this is vessels and these are the epithelial elements. So the diagnosis became quite obvious. And then retrospectively, I went and analyzed all these other features, which I spoke about. And for that matter, we decide to make a diagnosis. Now, the other immunostain that I did was P63, and you could see my epithelial cells and the tumor is quite positive. I also did Ki-67 because I was curious of the proliferation, particularly because there was low mitotic activity. And it was a triple negative tumor. This is just estrogen, which you can see positive ductal cells, and the rest of is negative. So I was very excited about that case because I don't know about how you have, but it seems to me that we, and both of us are presenting metaplastic carcinoma, that recently we have more triple negative and more metaplastic carcinomas than one would think of 1 or 5% category. I don't know, maybe it's just a fluke, but that's what is just general gist that I have. So this is what I'm showing. These are all these positive markers, and this SMA and P63 for the myoepithelial origin, and then negative desmin and SMMS, S100, CD34, and it was triple negative. So although this is not excision specimen, because of this colloidal stroma and general appearance, we favor metaplastic spindle cell carcinoma, low-grade fibromatosis-like. Metaplastic spindle cell carcinomas divided in low-grade and intermediate high-grade, and maybe an excision because she's older and mass is so big that even radiologists kind of said, oh, for sure, malignant. We don't know. Maybe it might turn out to be higher grade spindle cell carcinoma. But for now, I like this diagnosis for what I see. So any comments, any questions? This is my case. Basically, what I really wanted to say that many times did I order A1, A3 in spindle cell lesions because we talk about this spindle cell carcinoma, and they were never positive. And finally, if you do it many times, you get one.
Thank you, Dragana. That really nicely couples with Dr. Jessing's case of metaplastic carcinoma as well. So I'm going to open up to everyone. Does anyone have any questions that they'd like to raise?
Thanks, Dragan. I'm sure that was a relief to finally be able to definitively make a diagnosis on a spindle lesion on a core. Have you had the discussion with the surgeon? Do you know if they're going to proceed with a sentinel, or will they forego that given the diagnosis and the patient's age?
I don't know yet because this came through the private lab, but it is in our area, so I expect that she will be operated in Oshawa. It's also a recent case, like 2-3 days ago. So.
Can I take advantage of having, if Dr. Lee is still on the line, having him with us today and ask him about his practice in Nottingham in terms of metaplastic, and what percentage of a tumor do you want to see metaplastic features in to call it metaplastic? And do you report it as, you know, NST or whatever with focal metaplastic features, or what is your approach to?
I think we would just describe what we see. So we not uncommonly will describe mixed NST and metaplastic or whatever. So I don't think we so I think we often say if it's pure, it's pure. If it's mixed, it's mixed. I think that would be our
So
approach.
even if it's a very focal area.
If it was very focal, we would mention that it was very focal, and it
Right.
probably wouldn't affect the management very much. But usually there's a reasonable component, isn't there?
Mm-hmm.
So I have a question for the case presented. Do you think that your medical oncologist would consider neoadjuvant chemotherapy? Because on one hand, this is a triple negative tumor. On the other hand, is like a low grade and a special type of triple negative.
This is a bigger tumor. I don't know how large it is, but it's so large that it was presented as so. And recently, our oncologists have started neoadjuvant treatments on many carcinomas, even on a smaller size, and being metaplastic. I am not sure that they have that much experience, so that will be very interesting to know. And even sentinel lymph node removal is something, but if it is a large lesion, they have actually lately started neoadjuvant quite a lot as opposed to before. So I don't know, but I can always give you follow-up next time so that I keep you in suspense. And do you guys actually remove lymph nodes if they are removing the lesion or not?
Well, luckily, I'm not a surgeon, so I don't make this decision. I think that how old is this lady?
She is 77.
Yeah, I think that current management of the axilla is to do a sentinel node for women under 80, but maybe I'm a bit off here.
So in Sunnybrook, would she get neoadjuvant?
I think there will be a discussion because I think that if the tumor is very big, it will be really difficult to know or predict what is there in the other areas and whether this is exclusively fibromatosis-like low grade metaplastic carcinoma, or it's a combined NST and metaplastic where a neoadjuvant therapy is more reasonable. So I don't know. I think this would have been an interesting discussion.
Yeah, I kind of, when there are other tumors, I would, let's say invasive ductal carcinoma with mucinous features or something. But this one, I kind of felt, how can I call it invasive ductal with metaplastic feature? Because there's absolutely nothing there, you know.
I think it's when it was originally described by Paige as a really low grade. So it's, but when it's huge, we don't know what's in the rest of the breast. So I have a comment here: excellent cases and great opportunity to learn from experts in breast pathology. Thank you all for bringing these cases. And I think I can share, and thank you so much to Tilak for this comment. Thank you everybody for joining us. Special thank you to Dr. Lee for joining and staying with us for so late. I know it's we have a 5-hour difference with UK. Thank you, Jessie, for inviting Dr. Lee. And of course, huge thank you to Sharon, Anna-Marie, and Jessie yourself. That was absolutely an excellent session. Again, congratulations, Sharon, on your promotion. That's we all take a little part of that, and really happy for you. And we're looking forward to see you all in 6 months. Don't forget that you need to complete your evaluation if you're looking to get a CME. Once you complete, you will get automatic CME, and it will be emailed to you. And thank you, everybody. Thank you. Bye.
Thank
Bye
you.
now.
Thank you. Bye-bye.